speaker, and that's none other than past president of our IIRSI, past chairman scientific committee of our IIRSI, and my dear friend from Coimbatore, chairman of the Eye Foundation, Dr. D Ramamurthy, who has been a great guide for me as well, and he has really changed as during his tenure as scientific committee chairman. He really brought about a lot of radical changes in the scientific committee, which have done well for the AIOS. And he's a prolific surgeon, cataract and refractive. And I'll request Dr. Ramamurthy sir to please go ahead and share his wisdom. Now he's going to tell us about how he uses the Femto platform to have happy 20/20 patients, which would include several things, including astigmatism correction, which can be done on the Femto platform, and a lot of other things. So, go request her to speak.
Thank you so much, Gaurav, for this nice introduction, very kind introduction. I think a wonderful presentation so far. I hope I'm able to keep up the tempo. Obviously, both in the medical parlance as well as in the lay mind, laser is synonymous with perfection. So it's but natural that because of its increased predictability, reproducibility, and safety, we use it in the most commonly performed surgery in the human body, that of cataract surgery. And I think more and more we'll be using this as we go along. It's not just the availability of the femtosecond laser, but also the fact that the entire process is image guided. That makes me the surgery so much more attractive. This must be a very familiar slide for all of you. Capsulotomy, reducing the phaco power, making incisions, and handling corneal astigmatism are the advantages of this system. I'm going to be dealing with corneal astigmatism, which I feel is one of the aspects which is not much talked about when we talk about the laser platform, though we're constantly doing it. And I'm going to take a deep dive into it and see how we can optimize the laser arcuate keratotomies that we deal with. Most of us are aware that 25% of our patients have more than 1.5 diopters of astigmatism, and obviously these are cases where we want a toric intraocular lenses. But then there are almost 70% of our cataract patients who also have significant astigmatism in the range of about 0.5 to 1 diopter, and these patients are not amenable to a toric intraocular lens. That's the reason maybe that in Australia, the usage of toric intraocular lenses, where it's entirely subsidized by the government, is almost 70 to 80%. Obviously, in our conditions, that may not be possible. And this is exactly the segment which I feel would significantly benefit from the laser arcuate keratotomies, because once you deal with it, whether you're using a monofocal or a multifocal intraocular lens, the unaided visual acuity as well as the image quality is going to significantly improve. So as far as the basic information that we need to feed into the machine, most often we are discussing about toric intraocular lenses, the kind of formula that needs to be used, the kind of refinement that has taken place. Some of these limb relaxing incisions and laser arcuate keratotomies have not attracted that kind of attention. As was mentioned earlier by Maipal also, right through Asia Pac region, we have the version 5.0. And this does not have any in the catalyst, and this does not have a nomogram incorporated in it. And once the version 6 comes up, maybe we would have the benefit of using a nomogram that's inbuilt into the machine. One of the popular nomograms is to use the Donenfeld LRI nomogram, which is essentially meant for incisions at 11 millimeters. So when we are making our cuts at 8 or 9 millimeters, we reduce the arc length by about 33%. While the Julian Stevens nomogram, which was essentially meant for intrastomal arcuates, where you leave about 20% of the corneal tissue uncut, is something I do not use simply because I do not believe in that intrastomal arcuates help. I always open up my arcuates. What I use normally is the Varion, which is guided by the Holiday, and this is essentially meant for the penetrating laser arcuates. So the Varion gets the measurement, tells me where exactly to position my incisions as well as the arc length of these incisions. That's something I use on my catalyst. It's a marriage of two different modalities, but it obviously works well in my hand. Just as a matter of guidance, usually you require about 22 degrees paired arcuates at 9 millimeter for correcting about 1 diopter of cylinder. And when you go to about LRI for about 11 millimeters, you require about 30 degrees. So usually it's 1/3, that's the difference between these two. And but obviously it's better to be precise in your calculations. This is the kind of measurement that I have. I'm going to be dealing only with arcuates. Even for just about a 0.5 diopters, you can see that's a pad incision that I use, 32 degrees and 112. It's a 9 millimeter, and it's a good, if you want better effect, you can even go down to 8 millimeters. And let us go on to the video. And this is essentially the docking that is taking place. And I would like to, because I think it's extremely important for us to understand that we are going about 80% of the depth. If it's a 500 micron cornea, we go almost up to 400 microns is the depth of the incision that we make. When we talk about a capsulorhexis, it's about 300 microns offset. But here it's extremely close to the endothelium. In case the patient moves his eye or the docking is improper, there's always a chance, though we rarely ever seen it. I've just had one case so far where it could go right through and create a through and through incision. So essentially, when you are looking at your docking, it's important that you make sure there's a free area over there. And if you're looking at a penetrating incision, make sure that your incision is coming out. And let's move on. And basically, it's nothing much. It's capsulorhexis followed by nucleus fragmentation, which will just pass forward. In this case, it was just about a doctor of astigmatism that I was trying to deal with. That means about a 22 degrees of pad arcuate incisions. And it just takes about 2 seconds to complete this. I usually do not use the laser platform to create my side port incision. This is what you see under the microscope. The point I want to make is that even if I am seated temporally, even if it's the astigmatism is against the rule, which is most often the case, I go ahead and use the arcuates. And I feel that it does not interfere with my blade created incisions, which I am careful to ensure that it does not interfere the arcuate keratotomies. And that's the, this is the beginning of the surgery, but we'll quickly pass on to the end of the surgery. Gently hydrate the primary incision. Make sure that the globe is quite well inflated. Then open up these incisions quite adequately. I believe that unless you open up these incisions adequately, and actually you can see the scratch marks, the patients complain of a little bit of discomfort and irritation in the immediate postoperative day, even overnight, but I think it's worth it because that's when these arcuates actually work. And this is at the end of the surgery. And just in case I have arcuates with the rule astigmatism at 90 degrees, I go ahead and open these incisions up right in the beginning, even before I make my primary incision, because a well-inflated globe, this is when the incisions is extremely easy to open. So it's essentially going into the depth of the incision up to about 80%, and opening these up is important. And I find that that's when these actually work. So it's not just the magnitude of astigmatism that you deal with, as is our experience with the toric intraocular lenses. It's also the axis which is important. You can see over here a 0.81 diopter of cylinder, but it's with the rule astigmatism. What my machine suggests is no arcs are necessary. Obviously, there's no arcuate incision that's incorporated in this. On the other hand, you see a situation like this, where you find that it's just a 0.5 diopter of cylinder, but 174 is the steep axis. Obviously, with about a 0.5 diopters of against the rule astigmatism, the posterior cornea, you have almost 1 diopter against the rule astigmatism. Here, it's a good idea to go ahead and place a pad arcuate incision, which would deal with almost a diopter of incision, diopter of astigmatism. So, just like you would concentrate on the not just the magnitude of astigmatism, but also the axis of astigmatism, when you are implanting toric intraocular lenses, I think that should come into our minds when you are using the toric, when the arcuate incisions also. And whenever I'm using a multifocal intraocular lenses, trifocal intraocular lenses, etc., or the symphony lenses, it's extremely important that you reduce the amount of astigmatism that's left behind postoperatively. And again, you can see that it's against the rule astigmatism, 180 degrees incision that have been created. I find that debulking the astigmatism using this technology, whenever the astigmatism is less than 0.75 or 1 diopter, is a great way to go. And this is the pad incision that you see on the first postoperative day. And usually these are quite effective. I essentially was using a fair amount of limb relaxing incisions. gave that up because they were inaccurate, used to regress. But now that we have an image-guided technology, we have extreme control over the length and positioning of these incisions. The depth of these incisions is tailor-made depending upon the corneal thickness that's measured by the OCT on the table. And usually I leave behind up to about 20% uncut. Though there is you can leave up to about 50% uncut in the posteriorly, but this would not be effective. You leave just about 20% uncut. And it's also said that these incisions are titratable, that depending upon the astigmatism that the patient is left behind with, post-operatively, maybe a couple of days later, or even a week later, you can open them up on the slit lamp. I hardly ever tried that because what I get with these incisions under correction, and I believe that it's better to open it up on the table. And it's also important that we place the incision exactly where it is meant to be. And just like with our toric intraocular lenses, once there is these incisions not placed on the right axis, there's a loss in the effect that you get. With a 5-degree misalignment, you get about 1.5% loss. With a 50-degree misalignment, you get a 50% loss. But with a 30% misalignment, you get a 50% loss. With a 45-degree misalignment, you get almost 100% loss. So extremely important we align this exactly. Maybe the version 6 will allow us to do that. If I had my Varion linked to my Lensex, that's a possibility. But obviously, there are several other advantages to technology. I'm not going to go into the literature that is available, but a latest article by our own Ashok Grover, published in the 2020 Indian Journal of Ophthalmology, tells about the significant reduction of astigmatism that he was able to achieve. This is preoperative, the mean preoperative astigmatism, the vector corrected values, and the postoperative astigmatism. We ourselves are conducting a study. It's a thesis for one of our postgraduate students studying the Varion guided astigmatism correction on that on our this present platform, the J&J platform, and it's working out quite well. Our initial results are quite encouraging. The one-year results are awaited. I think maybe the next time I talk to you, I'll be able to share the results with you. I think we have had multiple excellent presentations on the difficult scenario, but most often we are faced with patients who have simple cataracts and their expectations are extremely high. And 95% of our cataracts belong to that category. The ability to deal with small amounts of astigmatism, which obviously translates into better visual outcomes in these patients, is a great benefit as far as laser cataract surgery is concerned. Thank you so much for your attention.
Thanks, Dr. Ramamurthy, sir, for that wonderful presentation as expected. And, I see that Dr. Sharad Babu, who has been using the femtosecond laser for about a few 6-8 months, and he's new to the platform. And it would be great to have his views on what change he sees in his refractive results and how he uses the femtosecond platform to get better visual outcomes for his patients. Dr. Sharad?
Yeah, up to 1 diopter of astigmatism, I'm using this platform. But then I'm using the same normograms which have been used by everyone. And of course, I'm getting good results with them. And more than 1 diopter, I'm using the toric IOLs. So,
absolutely. Dr. Maipal, sir, can you take it forward?
Yeah, let's go on to the next speaker, I think, in the interest of...
One question.
Sure. Yes.
So what are your long-term results of, astigmatic correction laser?
Actually, as I mentioned, Rohit, I mean, we are presently analyzing it in a prospective study, in the sense that, we have done on 100 eyes between 2018 to 2019. We are going to analyze that. The initial results seem to be quite encouraging. Definitely, it's not as accurate as a laser vision correction. It's essentially debulking of the amount of astigmatism that the patient has to deal with post-operatively. Usually, what I find is that if you initially have about 0.75 to 1 diopter of astigmatism, the patient is left behind with about 0.25 to 0.3. And over the long term, whether it regresses over time, like you see with limber relaxing incision, that's something that remains to be seen. but at least the initial results, especially with multifocal intraocular lenses, is quite good, and both as far as the quality of vision and the quantity of vision is concerned.
I think I completely agree with Dr. Ramamurthy, sir, that I find that with my multifocal lenses, any astigmatism below 1 up to 1 diopter, I find it to be a great tool to have better and better results and happier patients. Otherwise, we were always in a dilemma whether to put a toric and when you didn't have a toric. So I think, thanks, Ramamurthy, sir, you have absolutely echoed my thoughts and covered the subjects really well. And we will come back to a discussion on this after a couple of talks are over.